Hello, everyone, and welcome to the Natus Neurotraining Academy webinar presentation. I'm Dr. George Garziak, Senior Global Medical Education Manager for Brain and Neural Pathways, and it's a pleasure having you join us. Our webinar is entitled Sleep and Epilepsy Interactions, featuring Dr. Birgit Frauscher. Dr. Frauscher is a clinician scientist whose career is dedicated to improving the diagnosis and prognosis of patients with epilepsy by developing new methods based on advanced EEG techniques to better localize the epileptic focus in order to improve epilepsy treatment outcomes and ultimately achieve the best possible quality of life. Dr. Frauscher is director of the Duke Comprehensive Epilepsy Center and holds a secondary appointment with the Department of Biomedical Engineering at the Duke Pratt School of Engineering. Dr. Frauscher graduated from the Medical University of Innsbruck in Austria, where she completed her medical training, residency in neurology, and subspecialty training in electroencephalography, epilepsy, and sleep medicine. She also completed specialized training in intracranial EEG and signal analysis at the Montreal Neurological Institute and Hospital, McGill University in Canada between 2013 and 2015, and subsequently as an attending epileptologist and group leader of epilepsy and professor of neurology. Dr. Frauscher has over 170 peer-reviewed papers, and her research interests include the development of novel seizure, independent EEG markers for the epileptogenic zone, investigation of the important interactions between sleep and epilepsy, and the use of invasive intracranial EEG for studying brain physiology during wakefulness and sleep in order to better delineate normal from abnormal intracranial activity. Her scholarly endeavors have earned her several prestigious awards, including Clinician Scientist Awards from the FRQS in 2018-23, the Michael Prize Award from the International League Against Epilepsy in 2019, and the Ernst Niedermeyer Prize from the Austrian Epilepsy Society in 2015.
Thank you very, very much. I would like to thank you, George, and Natus for organizing this educational platform and for inviting me to talk about sleep and epilepsy interactions. I have no disclosures. I receive a speaker honorarium for this talk, but otherwise no disclosures related to this presentation. Now, I think, and I want to challenge epileptologists in general, that you can only be a good epileptologist if you have a good understanding of sleep. Why do I think so? I think so because there are important interaction between the two fields, right? On the one hand, we know that epilepsy very frequently can lead to sleep disturbances. On the other hand, we know that sleep disturbances, particularly sleep apnea syndrome, can aggravate seizures and epilepsy. And then also we have the differential diagnostic spectrum if we think to differentiate between sleep-related hypermotor epilepsy and parasomnia. And finally, and that's very important for us on the biomarker hunt to improve surgical outcomes by identifying excellent surgical targets to study the influence of sleep on epilepsy, seizure-independent biomarkers. And basically, because all of that, I think it's very important to also in our EMUs have a very good understanding of sleep. Then evidently epilepsy is not only modulated by sleep, also I really feel it's the strongest driver, the sleep-wake cycle, but then there are other cycles such as ultradian, circadian, infradian, and even circannual cycles as recently identified by data from the NeuroPace company. Okay, so just a brief introduction on the role of sleep in epilepsy. So in general, what I have here, that's a typical hypnogram, and that is basically what we do in sleep medicine. We usually have 8 hours of sleep where people are in the lab, and then basically we score every single 30-second page and attributed a label, and the labels range from wake, REM, N1, N2, and N3 sleep. And then basically as a final output, we receive here a hypnogram. And as you can see very nicely, it's that non-REM sleep decreases across the night, whereas REM sleep increases, as you can see here in that hypnogram. And that is related to sleep homeostasis, which is very important. I will talk about that later. But basically, we have that 30-second bins. Now, evidently, we can argue, you know, is it very physiological to have 30-second bins? I don't think it is, but, you know, it's manageable and practical to do so. And that's basically how we account different sleep stages for each of these 30-second epochs. Now, basically, grosso modo, we can differentiate. We have the non-REM sleep, we have the REM sleep, and then I already mentioned we have this sleep homeostatic pressure, which is important because if we look at the EEGs, we know very well that across the night, the power in slow wave activity is decreasing. And that also has substantial influence if we think of distribution of epileptic activity. I will talk about that later. But then evidently we don't only have our 30-second bins, but we also have our sleep microstructure, and they're in particular important, and we will talk about that also later, are the so-called sleep slow waves. And why are these sleep slow waves so important? They are so important because they orchestrate several rhythms in our brain and are usually characterized, and that is here what you can see here. Here are the single cell recording, and here is the macro electrocontact. And what we can nicely see here, that we have two phases of these sleep slow waves composed of a down state or deactivated state, as you can see, and an activated or up state where we have seen the discharges, and often physiological rhythms such as spindles, etc., coupled to the up state. So it's a very important element of the microstructure. We have others such as sleep spindles, or if you think of REM sleep, then we have basically the two portions of REM sleep that have fundamentally different function, consisting of the phasic REM sleep or REM sleep with rapid eye movements, as depicted here, and contrasted against the tonic REM sleep. These are those elements of REM sleep where we don't have rapid eye movements, as this depicted here. So that kind of shall set the stage of what we will discuss in the following. Now, the question then is, how can we use EEG to study sleep and epilepsy? And there are different options, and let's start from the sleep angle. So we can start from the polysomnography. So what we know for polysomnography, we usually have a very limited set of EEG channels, but then additional channels for EOG, EMG, and then all the cardiorespiratory monitoring. That's very important. What is the minimum, I think, if we talk about study of sleep in epilepsy, is to have a polysomnography, which is extended by the full 1020 EEG system as depicted here. Now, you can evidently push it further and combine polysomnography with high-density EEG, and there we have nowadays devices available with up to 256 channels. Or what you can do in the context of pre-surgical evaluation, where patients in the context of phase 2 pre-surgical investigation undergo intracranial EEG, you could pair this intracranial EEG with polysomnography, and most of the work I present today will be based on the intracranial EEG, and then some studies on the high-density EEG. Now, just some pros and cons of the advanced EEG technologies. If we talk about high-density EEG, so the good thing is we have a whole head coverage. I'm not saying whole brain coverage, right? That's what we don't have, but we have a whole head coverage. And the advantage is if we do high-density EEG, we can do it in the outpatient setting, you know, when the patient is on full medication, feels well, but evidently if we have very small generators below 6 square centimeter, or we want to record from deep sources such as the cingulate gyrus or the hippocampus, then likely we will miss epileptic activity unless we use very novel, sophisticated techniques to make that visible. On the other hand, if we combine polysomnography with intracranial EEG, what we will have is a high spatio-temporal resolution in the covered areas, right? So I think it's very important to realize that even if we talk about stereo EEG, even if we are inserting 18 to 20, which is a lot, electrodes in the brain, at the end of the day, we just record from around 10% of cortex. So the covered area, we have an excellent spatio-temporal resolution, but only in the covered area. But then evidently downside is, you know, it's sometimes difficult to combine with the sleep recordings in the surgical setup, because due to require close collaboration with the surgical team to set up scalp EEG wires. What we used at the MRI and also here at Duke is that we use needle electrodes, and that really works quite well for the complete implantation, and so we don't need to change the bandage. I already mentioned that we do not have a whole brain coverage. And then another disadvantage is evidently it needs to be done during the hospitalization. And patients are here to record seizures for pre-surgical workup. So medications are lower. They have many seizures. They might require pain medication after the surgical intervention. So evidently the circumstances of recording the environment is less ideal than it would be in the home or outpatient sleep lab setting. But that's just how much we basically can do. Now, just want to introduce also quickly, as we will hear a lot about it, invasive intracranial EEG and why we need it and what we do with this. For those interested in it, we recently published a seminars article in epileptic disorders about SEEG and its usage. So that is available for free download, open access. So invasive intracranial EEG is applied in pre-surgical evaluation, and the beauty of it is we can directly record neuronal activity from the cortex. I list here the indications, and there might in the meantime be more if we think of treatment indication with radiofrequency thermocoagulation, but these are the main ones just to get an idea. And then for many years, invasive intracranial EEG, there were basically two schools, the one with stereo EEG, and then the more American way to use cortical grids and strips. Now, evidently, that paradigm changed, and now even in the US, it's more and more SEEG that is used. And the reasons why is evidently it's much more comfortable for the patient. There are less side effects with stereo EEG versus cortical grid strips, but nevertheless, there can be complications with SEEG as well, up to 2% approximately, but with grid strip it was higher at 8%. And then evidently another reason is really we get this three-dimensional picture, and it was showed, and that was, I think, a very important step to now move to stereo EEG, that both are at least as efficacious, and for certain indications, certainly stereo EEG is the more preferable option. Now, how does such an electrode look? So here we have one of the commercial available SEEG electrodes, as you can see here, and then each electrode has contacts, and that might range in case of that type of electrode between 10 and 18 contacts, as you can see. And then basically what is very important, we really want to know where we record from, so we need to co-register, and there are different softwares available, commercially, non-commercial. That's one developed by our group, Rina Selman, within IBIS, and that's an example. And there you can basically nicely see this electrodes, and basically for those who are then interested to do research, you can extract the coordinates, and then you can put it in a template and then put together so many contacts over many patients. Now, how does that look practically spoken? So I already explained previously how such a hypnogram looks, and that's such a hypnogram. So we have here wake in green, and then in light blue is N1, N2 is in yellow, and then N3 is in this purple color, and then the REM here. So this is from one patient, and here I extracted a 30-second epoch. And what I highlighted here in blue, that's the scalp EEG that we had available in the patient. And here is a very small selection of the intracranial electrodes. And what we can nicely see here, spike in the polyspike activity in the fusiform gyrus here. And evidently, if we were to only have the scalp, we don't see spikes at all. So really the scalp can be blind to a lot of epileptic activities, and that's then the strong advantage to combine between these two measures. Now let's come to today's learning objective after this general introduction. So we will first review the bidirectional interactions between epilepsy and sleep. We will then discuss the latest evidence on spatio-temporal effects on sleep on epileptic activity, and to understand the effects of sleep on seizure network dynamics. So let's start with the first part. And please pay attention, because what we do, in fact, it's George who will do it. We will, after each of these learning objectives, have a small poll and then ask for to vote for your answers. And so please pay attention to that. So I think this is a nice slide, and I think many of you know that paper. It's really a landmark paper published by Markus Eng and Milena Pavlova in 2013, a meta-analysis where they simply looked in which sleep and wake stages are seizures distributed, as well as interictal activity. And basically what we can nicely see that they are not evenly distributed across the sleep-wake state, but we can nicely see that if we look for seizures, that the majority occur out of N2 sleep, however, only a minority, which is around 1%, out of REM sleep, for example. Now, similar for interictal activity, this is all normalized towards REM. That's why we have here a 1. And what we can nicely see here that we have highest rates of interictal activity in non-REM sleep stage N3, and compared to REM, a little bit higher. REM is still the lowest, a little bit higher in wake. And this was done across different studies, both in people with focal epilepsy, people with generalized epilepsy, both studies using scalp EEG and studies using intracranial EEG. But that's just to set the stage that really the rates of both seizures as well as interictal activity are really very dependent on the sleep-wake cycle. Now, we talked a little bit about it, but the question then is, we know that highest rates are in the slow wave sleep, but the question now is it uniformly distributed across non-REM sleep, or are there specific elements that are coupled to this epileptic activity? And so we already mentioned as a candidate marker the sleep slow waves. And usually they're characterized with frequencies between 0.1 to 1 Hertz, and they are really to be differentiated from the typical delta waves and spindles, which are the other most important feature of non-REM sleep. And as we said, we have the down state or deactivated or hyperpolarizing state, and then the up state or activated or depolarizing one. And what fascinated me at the time when we became interested in this topic was really that these slow waves activate and orchestrate physiological brain rhythms during the up state. And you know, when we started the journey, we were really thinking, well, maybe it's then the sleep slow waves indeed that are associated and trigger epileptic activity, and not so much non-REM sleep itself. And I will provide you the answer directly in that first slide. That's the work that we did do in 2015 at the time. And basically, we had an equal number of control and slow wave segments, and then we checked the distribution of two markers for epilepsy, the one epileptic spikes and the other high frequency oscillations, which is characterized as distinct events with at least 4 oscillations above a frequency of 80 Hertz. And what you can really nicely see with the distribution, around 80% of the spikes occurred during slow wave segments, and also the majority of HFO occurred during slow wave segments. But what is even more convincing to make this point is, here we have listed on x-axis the top amplitude percentile and the relative event density on the y-axis for spikes in blue and HFOs in red, and we can really nicely see that decay, that really the highest rates of spikes were associated with the top percentile high amplitude slow waves. Now, how to explain that? Well, we know that this is a state of a high synchronization, and so if that hypothesis is true, then it should be, if we look at a state with high desynchronization, that we have lowest rate. And we know that the most asynchronized EEG state in sleep is REM sleep. And that was very nicely shown, and it's really amazing work from Dr. Schaus at the time in the feline penicillin model, where basically she could actually demonstrate this point, right? And so basically here we have slow wave sleep, REM sleep, and then that's the penicillin trial during the normal sleep. And so you see basically here that the burst of spiking activity is really decreased. However, if we give a penicillin trial after administration of systemic atropine, then basically we revoke this suppressed activity, desynchronization, and spikes come fully back. And then what is very interesting in that context that I already mentioned, we have the two different states of REM sleep, the phasic and the tonic, and we know very well that the phasic is even higher cholinergic firing compared to the tonic. So if our hypothesis is true, then we should have really lowest rates of epileptic activity during phasic REM sleep, as this is the most anti-epileptogenic compared to the tonic REM sleep. Again, that's just here a picture of phasic REM sleep with the rapid eye movement, tonic REM sleep. We discussed that a bit before. And here is the result, that is work from our group, but also others from the lab of Nino Nobili, where we could nicely show that epileptic activity is more suppressed during phasic compared to the tonic REM sleep. And what we list here, that's different epileptic activities. We looked at spikes, ripples, then the fast ripples, which are above 250 hertz, and then bursts of epileptic activity. The phasic is dark blue, the tonic is light blue. And what you can very nicely see here is really that we have lowest rate in the phasic, and that is true on an overall level here, but also on individual patient level. We had 12 patients in that study. So really strong effect sizes if we look at that. And this is a picture from the work of Campana et al. From Lino Nobili's group, where they looked at different measures of synchronization in tonic versus phasic. And it means here, if it's above the line 0, means that it's more synchronized during the tonic as opposed to the phasic. And that's exactly what they could nicely show, that the EEG was mostly synchronized in the phasic, and the rates of epileptic activity in the phasic were lowest. So that highlights the role of desynchronization for inhibition or protection against epileptic activity. Now, it's important that we don't only have rates, but also other measures that are important. And if we think for localization of the seizure focus, then evidently it's important to pinpoint where exactly spikes are coming from. And what is very well known to those who read EEGs is that REM sleep shrinks the field of spikes and HFOs. And that is also something that we could show here. It's work from the lab from Alyssa Ho during her master's at the time, where she basically could nicely show. And let's look here at all channels. We have here wake, non-REM, and REM. And on the y-axis, the mean number of proportion channels per event. And we can really see evidently that the rates of propagated channels is highest in non-REM as opposed to the other states. And that is true for both the seizure onset and non-seizure onset zone, as you can see here. We then also looked for anatomy, spatio-temporal versus neocortical, and there we couldn't find a difference on that. That is the state, that's from work from Nicholas from Elreader that we did together at the time, where we looked at the variation in sleep state and the spread variation in time. This is ripples that we looked at, HFOs. If we look here and there, we can see that as well, that we really have the lowest number of channels involved during REM sleep as opposed to the non-REM sleep. Now, how does epilepsy shape sleep? So that is a study done by Laura Peter Dereks, and it's very interesting. I mean, everybody will understand if we have a focal to bilateral tonic-clonic seizure or a generalized tonic-clonic seizure, right? during sleep that we will wake up. Okay, yes, we all understand. However, what we found in that study is even if we have really polysymptomatic seizures or asymptomatic seizures, then still they frequently lead to awakenings. And that's an example here that's in the hippocampus, where you can nicely see limbic spiking. And then we have here the voltage fast activity, and around that time we see here then the awakening. And that again was a purely asymptomatic seizure, only characterized by the awakening. So seizures, definitely, even very small ones, disturb sleep. And that's what you can nicely see here, that basically there is nearly after every seizure at least a shift in sleep stage to a lighter sleep stage. For example, when you are in N3, then you are in N2, N1, or wake. So we really see that these seizures negatively affect the sleep and fragment the sleep. But then we looked further and looked, well, what are spikes doing? Are spikes, because very often we just see it as an innocent bystander and we don't treat spikes usually if we think of focal epilepsy. And what we nicely could see here also, that directly before the arousal, but then during the arousal, we see that increase in spiking activity compared to the baseline or the post-arousal window. And here, that's what we can see with burst as well. So truly, this epileptic activity is bisided. On the one hand, the epileptic activity disturbs the sleep. On the other hand, disturbed sleep also activates epileptic activity. Now, we found then that there is a different effects of arousal on epileptic activity, and it really depends on the type of arousal, whether or not epileptic activity is augmented or suppressed. And so basically, again, some tracings here. We noted that basically we have here a fast activity arousal here, and we can nicely see that epileptic activity here in fusiform gyrus basically was abolished. Whereas here we have a mixed arousal with a high slow wave content here, and there we really can nicely see, and that's the same patient, this increase in epileptic activity in the fusiform gyrus. And I don't only want to show some examples because it's always questionable, but this here is the summary of all the data, and we really could nicely see this relation between the power ratio in the scalp is in green here, and so that means a lot of slow waves. That means also more and higher rates of spiking activity for both the neocortex as well the spatio-temporal. Now, another thing evidently is then to say, well, this is not causality, right? We are talking about associations. What we found that many awakenings or arousals, and we found that during those with slow wave content, we have a significant increase in epileptic activity. So what we then did is, and that's work by Sana Hanan, that she will present at the ECE meeting in Rome later this year. But what she did in a couple of patients is that we induced arousals in patients, and then we checked also in the pre-arousal as well during the arousal, how do the global spike index behave, and what you can very nicely see here again, this increase. So it really is, I think, direct proof that this sleep fragmentation also deteriorates epileptic activity rates, as you can see here. And I will now break and give George to read the poll 1.
Thank you very much. So we have our first poll question. So we'll see if our audience has been paying attention. So sleep and epilepsy have important bidirectional relationships. Which of the following statements is wrong? A, highest rates of interictal epileptiform discharges are present in non-REM sleep. B, phasic REM sleep has the lowest rates of interictal epileptiform discharges. C, seizures occur most frequently out of N2 sleep. D, slow wave sleep uniformly increases epileptic activity. Or E, not only clinical seizures, but also subclinical polysymptomatic seizures can result in sleep fragmentation. So I will run the poll. and we'll see what our audience thinks. Let me see again. Well, it looks like 57% of our audience thinks that slow wave sleep uniformly increases epileptic activity is the wrong choice for this question. So there you go, Dr. Frauscher.
I would agree with that. I think I'm not a good examiner, but because I kind of gave it away. Unfortunately, the animation was lost there. But just to make the point,
Yeah.
so what we could show is that it's really the sleep slow waves which really seem to show the closest association to epileptic activity, and it's not uniformly distributed across the different elements, right, in non-REM sleep. So that's the point here. All the other answers are correct. Okay, so just a quick summary. So what I showed is that epileptic activity disturbs sleep structure, and even subclinical seizures and bursts of epileptic activity disrupt sleep. We know that sleep structure impacts epileptic activity, and that arousals seem really to be able to enhance epileptic activity. And I think that's very interesting if we think that the vast majority of patients with drug-resistant epilepsy, at least, have concomitant insomnia, disordered sleep. And then it's really the question, could stable sleep be a better tool to control seizure and be a new aspect? Okay, so let's move on to discuss the latest evidence on spatio-temporal effects of sleep on epileptic activity. Again, I don't talk much about it, but again, I think it's a very important work to keep in mind that epileptic activity is differently modulated across the different sleep-wake stages. However, then, does anatomy matter? And this is excellent work from Isabelle Lambert, from Fabrice Bartholomé's work in lab in Marseille. And basically, what they looked is this modulation and increase in spikes between wakefulness and non-REM sleep, is it expressed differently across different anatomical locations? And the answer, if I ask like that, is definitely yes. And what we can really see that the largest effect size difference, if we look at that in the mesiotemporal lobe, we have here in the dark green the non-REM sleep, and then the light green the wakefulness, and we can really see that there is a huge difference in the mesiotemporal lobe, and that is both true for ipsilateral as well as contralateral, whereas all other channels outside of that were grouped as neocortical. The differences were really smaller. However, what still holds true in general is that the rates of epileptic activity are highest in the seizure onset zone, followed by the primary irritative zone, and then the normal zone. So just to give a little insight, and that was also true across the different patients. So it really seems that there is a spatial anatomical component to it as well. And so what they found basically was that the medial temporal structure showed a greater propensity to spike increase compared to other brain regions during non-REM sleep. And the increase of integral spikes in the medial temporal structures was mainly the result of a local spike production. However, we don't know if spike suppression in REM sleep differs depending on the area. And there are some studies out to really show that, okay, there are less spikes in REM sleep, but some studies, and that's from studies in SCALP or high-density G-source localization studies, they reported spikes in novel coordinates exclusive to REM sleep, and I never really understood how that can be if we think that it's just that maybe the most extreme spiking and the most restricted sources are seen in REM sleep, but that is what was the notion at that time, and so we became very interested to look at it. And also, we know that spikes are less prevalent in phasic REM sleep, and we know that we have more phasic REM sleep in the second part of the night. So we also felt that spikes are lower in the second versus the first part of the night during REM sleep, and evidently also during the non-REM sleep, because the delta power and the amplitude of slow wave decreases. And that's basically what we looked here. That's data from 40 patients who underwent SEEG. And what we found, evidently confirmative information that spikes are higher in non-REM than REM sleep. But if we look here, we have here mesiotemporal neocortical, then we could see more suppression in REM sleep in the mesiotemporal lobe as opposed to other structures, as you can nicely see here. And the effect size was moderate with 0.4, as you can see here. So again, there seems to be a relation to anatomy. Then that's just overall on an atlas template to see how much it is suppressed. So there are some subtle differences also in the different neocortical areas, but across the board, there is a global suppression in REM compared to non-REM sleep. And then basically we also looked at the extent of the source or propagation of spikes and involved channels per spikes. And there we didn't find an anatomical relationship to that. And then if we then also looked at, do we really have, and that was work in SEG, novel coordinates in REM sleep. And again, we did this with a detector. So we have false positive. So we took this to normalize for it. And basically, no, the answer is we didn't find novel coordinates. And it was only in general a minority of channels. That's what is seen here, 12.6%, that had higher spike rates in REM than in non-REM. That's nothing new. That was described early on by visual analysis in studies from the 80s. But again, nicely shown that yes, for the majority, we have less spikes in REM than non-REM, but in a few minority, they have an increase in spikes during that. Now, again, we had this novel coordinate story from high-density EEG, and that is why two of my PhD students, Tamir Avigdor and Shifa Abdallah from the lab, we also did our own high-density EEG study to really very carefully look at that in 15 patients. Why such a small number of patients? Well, not every patient, as you know, has spikes during REM, and there is nice work out that shows if you have spikes in REM, then usually you have a worse course of disease than if not. But we had 15 patients who had a reasonable number of spikes across the different state of vigilance, and basically we used here a source localization method, which is very sensitive to the spatial extent. It's called MEM. I don't want to go there into today's lecture. But basically what we did is we did source localization in the different states of vigilance, and then we looked, is there a difference or change in result? And that is basically the main result. That's basically a patient representative patient example where you basically see that it doesn't matter where you do the source localization. And then we also had some metrics to confirm that across all patients, such as spatial dispersion or the distance from the supposed source. And basically what is reassuring is that if you do source localization, it's really not needed that you record overnight and then use REM sleep. At the end of the day, that was reassuring, and we could see we don't have novel coordinates. Source localization are the same. In contrast, it's mainly dependent on the number of spikes and signal to noise ratio. Now, we talked a little bit about epileptic activity distribution beyond sleep itself, and we talked about sleep homeostatic pressure. I will skip that. But what we can see here, if we look at pathologic ripples in that work, we really see that they decrease from the first non-REM epoch to the last non-REM epoch, for example. And that is another picture what I already showed from Alyssa Ho, where she basically could find that spikes are higher in the early sleep compared to the late sleep. Effect sizes were not on the high end side. They were rather small, the 0.2 and 0.1, as you can see, but still related to the sleep homeostatic pressure. And with that, we are now for the second poll, and I give it over to George. This time I don't give it up.
Okay, here we go. Number 2 poll question. There are spatial temporal effects of sleep on epileptic activity. Which of the following statements are true or is true? Rates of epileptic activity are higher in the second part than the first part of the night. Spike suppression by REM sleep differs depending on anatomical location. results of electrical source imaging are comparable across the different states of vigilance. D, all statements are correct, or E, B, and C are correct. So again, you look at it, decide on your choice, and here we go. Well, it looks like 60% of our audience that responded chose E, B, and C are correct. All the other ones were in the teens or single digits, so 60% predominant.
Cool, yeah, exactly. Voila, that's the right answer. E. Now I didn't give it away with the animation issue, sorry for that. But basically, if we look at A, is that what one could show is that the rates of epileptic activity, they are really correlated with the sleep homeostatic pressure, and as we know, they're related to the high amplitude slow waves, and they are the least frequent in the phasic REM sleep, which however is the most prevalent in the second part of the night. It's clear that I just exchanged these two. So the correct answer would have been rates of epileptic activity are higher in the first part of the night than the second part of the night. Yeah, so so that was wrong, and then B and C are correct. So we could see in different papers that really it's anatomy which makes a difference whether we are in the mesotemporal lobe or whether we are in the neocortex. And then for C, really, if we look at source localization, do it in the different states of vigilance, then we really get the same results. Again, I think the most pertinent for ESI is really to have a good amount of spikes and to have a good signal to noise ratio. What we did in that study I showed is that we normalized to the number of spikes, because evidently we have lowest rates in REM sleep. So we took the same amount of spike numbers to even out for that. But so statement E is correct. Okay, so let's continue. So that's just the summary. So ID suppression by REM sleep differs depending on anatomical location. REM sleep restricts the spatial extent of spikes and can thus be important for precise localization of seizure foci in epilepsy. And I really think that's something very useful if we do our pre-surgical phase 1 workup. And for example, if one has, and that's old work from Jean Gottman and Samaritano, published in Neurology, I think 1991, but they had people with bitemporal spikes, and then in case of unilateral seizure focus, it's very useful to look in REM, because very often there you see then the spikes only on the affected side. We didn't find novel regions of IEDs during REM sleep, at least as measured with the intracranial EEG, and then the rates of epileptic activity differ depending on the time spent in sleep, with higher rates in early than late sleep. Okay, let's move to the last part to understand the effects of sleep on seizure network dynamics. Okay, so that's again a slide we already saw 3 times today. But point here is seizures are more frequent on REM sleep, and it's particular N2, and we only have 1% out of REM sleep. Another important fact is that we know, and that's very nice work from Barbara Jobst and Sue Herman, that seizures in the mesotemporal lobe, they generalize more frequently during non-REM sleep as compared to wakefulness. So this is all known facts that we have, and then evidently we have different types of epilepsy, and we have particularly, if we think of sleep-related hypermotor epilepsy, that's the type of epilepsy where per definition more than 90% of seizures occur during sleep. But in general, if you look at duration, then that was already showed, I think that's from Sue Herman's paper, that seizures are not longer in non-REM sleep compared to wakefulness, but that's basically all that we know about spatio-temporal seizure dynamics, and the effects of sleep on seizure topography is very poorly documented. And we really thought this is something which is first scientifically super interesting questions, right? Is it that, for example, and people suppose that maybe the seizure onset zones are famously large in non-REM sleep? Is it that in general seizures are longer? Is it that seizures involve more channels during a seizure, etc., etc.? So a lot of interesting questions to ask. And that's basically work from Sana Hanan that she did while being in the lab, where we looked at seizure characterization during non-REM and wakefulness. And evidently, it was not a real easy endeavor, because what we really wanted to have is a patient that had within 24 hours both seizures in wake and non-REM. Why the 24-hour criterion? It was to exclude that it's a decrease in anti-seizure medication that makes a difference or not. So basically, in our big database at the MNI, we finally ended up identifying 25 patients fulfilling these criteria. And now these are the markers we were interested. We were interested to look at seizure onset patterns. We were interested to look at spatio-temporal propagation. And we were interested to look at epileptogenicity as assessed with the epileptogenicity index, which is basically an index that expresses and combines when fast activity occurs to the moment in time it occurs. That's the measure we assessed for ICTL. And then as an active comparator, we looked at inter-ICTL IEDs as well in both wake and sleep to kind of replicate what we already know, that there are differences between wake and sleep. So that's basically what we did. It was very laborious work, as we visually marked on each single channel, and that can be over 200, where a channel has the onset in the seizure during a given seizure and then the offset. That's just an example how that markings basically were done. And then for the differences in time occurrences, we then really put together clusters of 500 milliseconds and channels that were involved within the different clusters. And basically, I can make it very short, that part, but the spatial distribution of seizures was not affected by the vigilance state. That's just some images to illustrate that, because we know not two seizures are totally identical, right? That's an illusion, but they're very similar. And so basically here in that patient example, we have here the different channels. We have here the time on the x-axis, 2 seizures from wake, 2 seizures from non-REM, and grosso modo, I don't think one can say they look really very different. That's then also, if we did our stats here, that we found that a similar amount of channels is involved in the seizure onset zone, as well as the maximum number of channels involved in the seizure, really identical, no effect at all. Here, spatio-temporal propagation. So what we looked is seizure duration, latency to maximum channel involvement, number of propagation clusters, and then the mean difference in cluster onset time. And again, we didn't find on a stats level any differences between those. Here, this is the epileptogenicity map for a seizure in wake and non-REM. As you can see here, that's what we computed with AnyWave, which is a freely available software provided by the Marseille group. And basically, they really show a very similar pattern. And then if we look for epileptogenicity index above 0.3, we really find it localized here to posterior insula in both circumstances. Again, no difference at all. And then we looked, is there more difference between intrastate as well as interstate? Again, there was nothing significant on that. And I think that's probably the most interesting figure here, because here we have spikes, here we have seizures, and we really have here the channel overlap between wake and non-REM, right? The overlap which have both in common. And so we see that this is significantly less for spikes than for seizures, and this was a moderate effect size at 0.5, what we can see here. So the spatial overlap between wakefulness and non-REM is higher for seizures than spikes. Now, I want to stop here and give over to George.
Okay, thank you very much. So we have a question here. Which of the following statements regarding seizures is wrong? A. Seizures in mesiotemporal lobe epilepsy generalize more frequently in sleep than in wakefulness. B. Seizures are rare and occur at about 1% out of REM sleep. C. Spatial overlap between wakefulness and non-REM sleep is higher for seizures than interictal epileptiform discharges. Seizures follow the underlying network irrespective of vigilance state. Or E, the last choice, seizures are longer in non-REM sleep than wakefulness. So in this question, our audience thinks it's choice E, seizures are longer in non-REM sleep than wakefulness, 49%. 27 and 23% were for B and C respectively. So the majority is 49% for choice E.
Right, to make it short, that's correct. So it's two studies who looked at that, and both scalp and intracranial, and it was found that the duration is not significantly different between non-REM and wakefulness. Now let's go for question B. Well, this is the number taken from the meta-analysis of Marcus Eng. So, you know, we can have seizures out of REM, but usually it's really rare. What's also quite interesting is there's more and more studies coming out that show that and one very interesting one that looked at drug-resistant epilepsy versus well-controlled epilepsy, and they found that people with drug-resistant epilepsy, they have less amount of REM sleep or lower percentage of REM sleep during the night, and a change in the tonic to phasic ratio with more tonic REM sleep as opposed to well-controlled epilepsy, which also goes well along with the anti-epileptogenic properties of REM sleep. The other question was spatial overlap. Yes, so basically we found that in the seizures we had more channels that were activated during wakefulness and sleep, whereas if we look at spikes, right, spikes are usually more constricted in wake than they are in non-REM, so there was less overlap between the two conditions. All right, now to sum up this part of the work, in contrast to its effect on spikes, non-REM sleep does not affect the spatio-temporal dynamics of seizures, and the results suggest that once the brain surpasses the threshold for generating a seizure, it will follow the underlying network irrespective of the vigilance state. And we felt that's interesting because it offers valuable insights into neural network dynamics in epilepsy, but it's also reassuring that if we think on our everyday doing, it really doesn't matter much for determining of the seizure onset zone, whether that occurs in sleep and wakefulness. So now that's my last slide, I promise, to sum up and conclude. So I hope I could convince everybody that sleep is an important modulator of epileptic activity. There are important bidirectional interactions, and there is still a lot of more research to do in the field. Sleep is not uniformly affecting epileptic activity, but there are important spatio-temporal effects. And then the effects of sleep differ between ictal and interictal network dynamics. And with that, I would like to thank our clinical team, my lab, and you for your attention. And George, I think we have still a couple of minutes for questions left.
Yes, thank you, Dr. Frauscher. Let's see, we have a question from a colleague here, and they're asking, can a sleep spindle, I guess, be epileptic? Or how to differentiate a normal or abnormal?
Yeah, that's a very, very good question, and one could probably have a lecture on that topic itself. I mean, basically what we do know, and I didn't discuss that work here, but we basically, there is work out which shows that you have spikes in the hippocampus, and that has both local but also widespread network influences and can then evoke spindles at other locations. And we know very well spindles are important for learning, and if it's not well coupled with slow waves or the typical trains of spindle, then these pathways might be disrupted. And then there is also the notion of spindle length that has been reported. And then evidently, if we look at intracranial EEG, sometimes you can see type of, I wouldn't say it's not a spindle, but it has, I mean, the same frequency, but it's very sharply contoured. It is basically a polyspike activity that I also saw already, but I think that's electrophysiologically to be distinguished. But yeah, sleep spindles itself could be a topic for an hour to see how it's negatively influenced by epileptic activity. And we know in focal epilepsy that we have less spindles at the side of the focus as opposed of the non-affected lobe. And another thing is evidently, and that's old work from the MNI from the 78s from Glor, where in generalized epilepsy fill-in model, they found that basically these physiological sleep spindles then evolve in generalized spike wave activity. But it's a lot of discussion. I don't know if this answers, maybe.
It made sense to me. I think you should. So, how about this question? I think we have time for this one as well. Do you have a hypothesis explaining increased rate of spiking after awakening in some epilepsy syndromes? Has it something to do with the sleep inertia?
Yeah, it's a very, very, very good question, and that's probably a question that could best be answered in experimental research, which evidently I work with humans, but I think in general, and I think that that it's also with seizures that it's always not in very stable states, right? If we look, for example, also at the cyclic alternating coupling pattern, if we look at the cup patterns, right, then it's also, if we look where do seizures from sleep-related hypermotor epilepsy occur, then it's also usually, you know, first half of the night and out of and 1 and 2 sleep when things are not so stable, when it's kind of at the edge. And I think in general, all of these state changes, you know, are problematic, and probably there it might happen from the sleep and wake, but I don't have the exact mechanism, but it's interesting.
Okay, thank you. Maybe just one quick one. How does epilepsy surgery affect sleep? I guess after the surgery, or does it not?
Yeah, there is work out. I don't say it's a huge body of evidence, but there is work. It's older work out that looked at polysomnographies before and after surgery, and what they found, evidently, if patients get seizure free from surgery, sleep improves, and that also totally makes sense, right? Because we know that seizures have profound effects. So, for example, we know if you have a seizure in the evening, then usually it takes longer to fall asleep. You have less REM sleep time, or the REM sleep is delayed. So, and then there is many subclinical seizures that you would not even see if you look at scalp only, that then leads to sleep fragmentation, and evidently even the spikes can result to sleep fragmentation. So it's not surprising if epilepsy surgery, in generally spoken, this is just now in general spoken, not for a specific type, but if it goes well, that improves sleep. And that also reminds me, if we talk about neuromodulation as a surgical approach, there is nice work out from the group from Zurich, where they could show that if they do deep brain stimulation in the patients that responded well and had a reduction of seizures, they also had an improvement even in the sleep macrostructure.
Okay, well, thank you very much. So, on behalf of Natus and our Neurotraining Academy, it's been a pleasure having you join us. And again, I would like to thank our speaker, Dr. Birgit Frauscher, and this will conclude our presentation.